Assalamu alaikum wa rahmatullah. In the name of Allah, the most gracious, the most merciful. I would like to welcome everyone to today's event in collaboration with the WHO and multiple national governmental entities in Saudi Arabia. Today, inshallah, we will share with you some of KSA's efforts and experience in fighting COVID-19. And my name is Yasser Al-Asqi. I'm the Director General of the Saudi Patient Safety Center. COVID, as everyone lived through the past 2.5 years, touched all of our lives and definitely affected patients and patient safety significantly. The efforts that was done by the Saudi Arabian government in collaboration as one team is something that I am personally very proud of, and this is part of what we are going to share with you today. Before we start, I would like to thank all of you for attending, and also I would like to thank all of our guests and speakers for honoring us in sharing this experience with us. I would like to present our moderator for today, Ms. Lamia Al-Hazzani. Ms. Lamia is the director of the patient safety of the patient empowerment department here in the Saudi Patient Safety Center. Lamia.
Assalamu alaikum, welcome everybody. So I would like to introduce our first speaker, Dr. Imad Lafi Al-Muhammadi, from Preventive Medicine and Public Health Consultant, Chief Officer of Communicable Diseases Control in Public Health Authority, and member of National Committee of Infectious Diseases. Welcome, Dr. Imad.
Thank you, Lamia. Thank you, Dr. Yasser. It's a pleasure to me to be here today with you in this seminar, and I would like to thank the organization committee and Saudi Patient Safety Center for this invitation. My name is Imad Muhammadi, as Lamia said. I work with public health for past 3 years now, and in next few minutes I will try to summarize the effort of Public Health Authority during COVID pandemic. Next, please, Lamia. I will take this opportunity to talk a little bit about Wiqaya, Public Health Authority. It's a new entity. It started as a Saudi Center for Disease Prevention and Control, Saudi CDC. And in the Paris the current CEO was appointed in March 2018. In last meeting in 2019, the board recommended to independency of this center to be a public health authority dealing with public health threats and events. And in March 2021, transformation of the National CDC to Public Health Authority was made through Cabinet Resolution number 401 to be independently, financially, and administratively. And in last October, the Paris board was conducted. Next, please. In Public Health Authority, we focus on all spectrum of public health. Starts with health promotion, mainly for non-communicable disease and environmental health protection, and through public health emergency preparedness and response using all hazard approach, and manpower planning through Public Health Academy, and laboratory, basic reference laboratory and gene sequencing, biobanking, biosafety level 3 and 4, and information through multiple surveillance system, and conducting and organizing research regarding to public health. Next, please. Today we will focus on infection control and patient safety. As you know, the infection control is one of the patient safety goals to reduce the risk of health acquired infection. Next, please. During the pandemic, Public Health Authority developed and published many guidelines regarding to patient safety, focused on infection control guideline. One of this protocol or guideline published in January 2020, after 1 month of emerging the SARS-CoV-2 in China. And we built this guideline based on our experience in MERS-CoV. The guideline contain a lot of things, mainly a case definition, updated case definition, infection control recommendation, lab diagnosis, recovery criteria, and etc. And also regarding to the situation in the first wave and the risk of shortage in PPE, we develop a guidance for extended use and limited reuse of N95, and also we produce a guideline about dealing with dead body and vaccination. Next, please. As one of main infection control policy, where we adopt the respiratory triage policy, which was implemented before COVID, to cover COVID and MERS and other respiratory illnesses. It's the designated area triage in entrance of ER and hemodialysis department, with required PPE as face mask and gloves and hand hygiene sanitizer and tissue. It's covered by trained nurse, which can communicate in Arabic and English, and using the approved triage scoring for MERS and COVID. If the patient score more than 4, the patient will advise to wear a face mask and perform hand hygiene and directed to respiratory waiting area. Next. This is the checklist, visual triage checklist. It was before COVID only for MERS, but we updated it to cover both MERS and COVID. It's divided into main part: exposure risk and clinical sign and symptoms. Next. This is the respiratory waiting area, a designated area for a patient with respiratory symptoms or risk for contacting with a confirmed case of MERS or COVID. It's with social distancing between the chair. That's implemented before the COVID also. And trained physician will take decision about what next steps for the patient from investigation and etc. Next. Next, please. After easing a lot of recommendation of restriction, such as lockdown and etc., the healthcare to ensure the safe return of healthcare services, such as elective surgery, Public Health Authority developed this guideline, contain a guidance about a screening patient prior to their scheduled surgery, and standards that should be applied during operation and after operation to minimize the risk of infection during this. Next. Again, also we developed a guideline specific for healthcare worker to prevent spread of healthcare facility between spread the infection in healthcare facility between healthcare worker and patient, or between healthcare worker themselves. It has a standard to return of any healthcare worker who is exposed or infected, and it's updated regularly according to best available evidence. Next, please. This is the last update of this guideline. We divided it into 3 possible scenarios. If there is no shortage, it's as public, it's have to spend 7-day isolation. If there is moderate shortage, with arrangement with regional command and control center, can be reduced to 5 days. If there is a severe shortage in staff, and with approval of Central Command and Control Center, healthcare worker may contain their duty if they're able to that. Next, please. For general population, we developed a lot of guideline in coordination with other stakeholders, and it's based or contain the basic infection control measures such as social distancing and universal masking, or limiting the entering or attend any social, economic, commercial event to fully vaccinated, depend on status on Tawakkalna. We published more than 200 specific protocol for this general activity, and with MOH we have a lot of auditing round to assure the compliance. Next, please. We are proud to develop a lot of special protocol for special events, just such as GCC Summit, the Future Investment Initiative Forum, Dakar, Formula E, Formula, other sport events and mass gathering events during this to minimize the risk of infection in this event and continue or try to back to normal life. Next, please. Regarding the global health, from first cluster of cases in China, we developed a risk assessment tool, and we do a weekly risk assessment for all countries and share with the main committees, and published in the website twice monthly. And we develop a lot of guidelines and updated it. The recommendation about pre and post arrival PCR and quarantine period according to the country before departure to Saudi Arabia. This is in summary the effort that have been done from Public Health Authority team, and I would like to thank everybody. We work with all departments in almost all in Ministry of Health, and we work with all ministries in the kingdom, and we're proud to have this small effort as a team member with other. Thank you again for organizer, and thank you.
Thank you very much, Dr. Imad. Much appreciated, very informative presentation. Now we would like to move to the next presenter. Okay, I will read one question for you, Dr. Imad, if I may.
Sure.
A question to Dr. Imad: how do you keep up with the evolving evidence in regards to screening and treatment of COVID-19 in KSA, and how often do you update the guidelines?
Okay, we update the guideline as needed. We have a scientific committee formed from experts from many stakeholders, and we met now more than 40 times, and we have more than 100 recommendations. And this committee review the evidence, the new research, the benchmarking from other countries and their experience to update the guidelines or protocol as needed.
So Dr. Imad, correct me if I'm wrong. I think one of the unique things about this committee is that is a national committee hosted by the CDC, but there are representatives from all sectors.
Yes,
expertise from all sectors.
Yes.
So it's more of a national committee. So whatever guideline is released by this committee is immediately adapted by everyone because they were shared, or they shared in decision making and in creating these guidelines or decisions.
Yes, we all work of WQAIDs through the committee, even scientific committee or other committees, because it's we have to discuss the protocol with main stakeholder to assure the compliance with this protocol.
Thank you very much again, Dr. Imad. We will go to our next speaker, Mr. Walid Hamroud, Director General, MOH Contact Centers, expert in services, quality, and beneficiary experience, interested in innovation and excellence. Welcome, Mr. Walid.
Thank you, Lamia. Good morning, everyone. I'm glad and honored to be in this seminar. Thank you to Dr. Yasser and the team for the great organization for this seminar. I'm glad to share with you here today the 937 experience in fighting COVID and how that's supported the patient safety and the human safety across the kingdom from Ministry of Health perspective. If you can go to the next slide. So 937 working in the community and with the community to evaluate and improve the health services and create a wave of change and build the trust. So Ministry of Health very keen to create healthy environments in terms of general satisfaction with the provided health services throughout the kingdom. Effective network of 937 within the regions and medical cities and specialized hospitals, and great collaboration with other entities to make sure that we are covering the sector the right way and being the voice of people and the respondent to people and the confident place to have the right answers and support from the ministry throughout this pandemic. 937 for everyone has been established like 2013, 2014 as a small operation room, and it's got scaled up within time. In 2020, we were like almost 300 to 400 staff. The number has been exceeding 3,000 staff during the pandemic to provide the needed support to the community. So going to the next, let me tell you what is our role during the pandemic, being a platform in the main committees, executive committees of Corona, to provide the voice of the community, as we are the direct interaction platform with the people in the kingdom, regardless if they are citizens, residents, even the unknown who doesn't have any identity, as royal decrees and directions has been done. So 937 directed and supported and contributed in the application of public health protocols. So whatever protocols has been launched and updated, 937 is the channel to make sure that all the answers being provided, giving the directions for people to follow these protocols, being with the effective network of 937 in all regions, the voice of truth during the pandemic. This is in line with the daily conferences, media conferences, and weekly conferences that's been done by the ministry, as well answering the medical inquiries and consultation related to the new coronavirus or the vaccination. Since we started, lots of rumors and things have been circulated against the COVID truth and the support of the vaccination. And our role here was to make sure that we fight these rumors, to make sure that everyone are safe and not following these kind of rumors that giving the transparency kind of things. And this is being done with laboratories and everything, as well the vaccination and the things being done with the vaccination. So we were, again, the sound of truth, that's giving the rumors the right information to be dealt with. So everyone were aware in the community with the 937 efforts in the social media and through the calls and all our channels to make sure that we provide the right information for people and answering in regard to these rumors that circulated against COVID truth. So submitting periodic reports and daily indicators. So 937 has multiple operation rooms and attendance in different committees for Corona. So we are providing reports in regard to whatever contains issues, incidents happening with the community, to make sure that we provide the needed information to the decision makers at the right time to make the right decisions. So that's been said. It's not only a daily. Sometimes it's go to an hourly basis in certain information. We do facilitate the access for beneficiaries by the Ministry of Health during the quarantines and all kinds of actions being done with this pandemic. When the quarantine happened partially or fully for everyone before going to the institutional quarantine and everything and opening the country, we were also the place for people to ask and get the guidelines in dealing with this quarantine and how people can move from place to place and so on. Going next, please. Here I will give the 937 contribution in 4 pillars. We do the communication and the exceptional services, and we did launches for a couple of services. And as well, we were posting in social media and any other places to make sure that we can contribute to everyone. Going next. Okay, so in the part of the communication, we do have several channels for the 937 contact center to help the citizen and residents and whomever living in Saudi Arabia to access our services. We have the calls channels. We have the chats, the chatbots, the WhatsApp, the Twitter accounts, the email accounts, as well the Ishara app, which is supporting the sign language, so we can also reach these valued citizens and residents who speak the sign language. So since we started from the communication pillar, we did communicate with all whom coming in the from Republic of China in the start of 2020, when is the before the pandemic is being declared. We started to call everyone coming from China just to fill a questionnaire to make sure our team members from public health get these kind of information to deal with the situation and in the war rooms that were created in advance. We did as well mentioned before from the communication that we determining these rumors with heavy activities throughout social media. We did as well communicated with the high and medium risk cases. The ministry launched through Maw'id application everyone in the beginning of the pandemic to assess their cases from the questionnaire that appear in the application. So whomever scored high or medium, 937, we're calling those people to make sure their situation, their health conditions are okay. If they are really in risk, we are directing them with giving them the ability to have their appointments and their the COVID test right away. So we make sure that they get the needed help and support. And that was in the beginning of the pandemic when everything was not clear for everyone. The center as well with the care that happened in the first as well, when is Qatif city were quarantined as the first city when the pandemic started. Lots of support happened from 937 for our people residing in Qatif city. We supported the needed direction. We give them the needed support to get their health support, as well the guidelines for them as a protocol that being issued for people in Qatif and whom going out and in for Qatif. So this is from part of communication. Let's go next. So from post, 937 contact center participated with the continuous production of reports, updating the daily and new indicators to the leaders to make sure that they are getting the right information at the right time with the external stakeholders, internal stakeholders, to perform their task, identify opportunities to deal with this pandemic. So contact center participated, 937 participated in the active survey based on the voice of the beneficiaries. We see where is the high volume of people and high risk and everything, and then we divert the active surveillance with the public health and support them with this information so they can make decision which area to go first. As well, the technical team in 937 supported and participated in building the self-assessment that I mentioned before for the application of Maw'id based on the voice of people and how we are getting their information from there. As well, 937 contributed in the emergency media operation room to raise the awareness about the COVID-19 by submitting different reports in what is the public is asking and concerned about, to make sure that it's being dealt through media the right way and giving the right information. As well, we improved and participate in improving the user experience for the applications in Maw'id and in Sahati. Going next. Next, please, Lamia. Okay, so during the pandemic, 937 acted fast to contribute multiple new channels and launch new channels for the public. We launched interactive chatbot services, immediate response in the WhatsApp with verified number in collaboration with Facebook, which is Meta now. And we also added it in the MOH website. As well, we launched Ishara, as I referred to it before, which is for the hearing disabilities people, helped us to reach to those people and answer their inquiries and medical consultation 24/7 with the sign language. As well, we provided through the pandemic, as we have lots of people speaking different language resident in the kingdom, we provided 8 different languages responding to the community. We provided Urdu, Persian, Ukrainian, Russian, Turkish, Bengali, and Tajikistani and Rohingya, and as well French. Going next. Okay, so from the part of exceptional services, our reports supported in launching the fever clinics that's been considered and accredited with the value of the fever clinics, which is called Tamman, from the Lancet magazine, and this is a huge support that 937 saw the need with the other KPI indicators, the need of having a fever clinics which get the ideas circulated and launched immediately to support the people whom showing symptoms of the new corona COVID and monitoring the actual need from the community. And as well, 937 contact centers worked as well once started Tatamman clinics, as well launching Tatamman application, which was directed for people who are infected to help them during their infection period with the needed information and support and health support during their home isolation. As well, our issued report of medical test results, and sometimes we are monitoring any incidents from people that are having delay in having their medical tests of COVID results coming out. We did improve that through our reports with support with the stakeholders to make the kingdom rank globally in the speed of the results appearance as a high rank. As well, 937 Center initiated and conducted the first ever meeting, included all the directors of all contact centers and the government agencies and authorities to coordinate and collaborate of raising the level of services providing during the pandemic. Here, I mean, with the aviation authority, with the passport authorities and with internal authorities. We conducted this meeting on regular basis just to make sure that from a government perspective and as a Ministry of Health is leading the show, that we can support other entities to respond to their kind of protocols and that linked with the health conditions. Going next, please. So in the vaccination phase, after SFDA approved the first COVID vaccine on December 10th, and pre-vaccination campaigns have been launched for everyone in the kingdom, regardless of your nationality or resident status. So we monitored in 937 all the any reported side effects of the vaccine through a line automated through 937 center, as well communicated with the first category of high priority groups to obtaining the coronavirus by booking appointments. We were calling everyone categorized as a priority, from the elderly people and whomever have diseases that needs to get the vaccine right away. We were booking appointments for them, reaching out for them, and as well we contributed to the health awareness of the coronavirus, providing the medical consultation needed and how to obtain the vaccination. As well, 937 took a part in the committee for the vaccine for standardization, the processes and quality management through the committee's resilience and the reliance on the reports of the center, following up to ensure quality of unified operation procedures through the incidents that we are reporting through 937 from the community and public people. So within the vaccination as well, we did supported the people at home who cannot come to get a vaccination from the vaccination centers by booking appointments for teams of vaccinations, going to them at home and giving the vaccination at home for these people who cannot reach out to the center of vaccination. Going next. Okay.
Dr.
So,
Khalid, we
hello?
have 3 minutes left for this presentation. Thank you.
Yeah, sure. Closing soon, inshallah. In 2020, we exceeded 24 million calls that been served. In 2021, we exceeded 37 million calls has been served with 91 call satisfaction, 90 service satisfaction. We dealt with more than 1 million tickets raised through the center with average calling time of waiting time with 12 seconds. These kind of numbers as a benchmark internationally is great. I think we can compete with it. We dealt with 2.7 million Twitter cases, 4,000 Ishara calls services. Going next, please. So here we do thanks our partners who worked with us, and it's not only for those mentioned here, but all of these partners were supporting the 937 network and responding to the community. So we take the opportunity to thank them all, because our success was not to be done without all our partners, even whom not mentioned here. 937 working with everyone to make sure that the voice of people and the respondent to people are in high quality with the right information at the right time. I'm very pleased to be here. Thank you again for Lamia and the team for organizing. Dr. Yasser, thank you for the Saudi Patient Safety Center. Thank you for WHO for giving us all the opportunity to share our experience during this pandemic.
Thank you, Mr. Walid. Thank you very much. Actually, we have a question for you. Who responds usually to the patient's complaints and give medical advice? I mean their specialty, and in case one of the patients needed a medication during the pandemic, how do you usually provide it to them?
Okay, so we have specialized doctors whom responding to the medical consultations. We have a specific queue and service number for everyone who needs a support and medical consultation. So a specialized doctors, well trained, are responding to the concerns and making sure that each case has been dealt the right way. This is one. Two, in regard to the complaints and the issues that being faced, as well, we have trained staff, not necessarily a medical ones, and related to capturing these kind of complaints or incidents, and make sure that we are directed it to the right team to make sure that it's been dealt with a timely manner and high quality and satisfaction rate.
Thank you very much, Mr. Walid, for this informative presentation. Amazing numbers. Thank you very much. Now we will go to our next speaker, Dr. Mohammed Al-Tuwajiri. He is an emergency physician and now is the Executive Director of Medical Affairs in the Saudi Red Crescent Authority. Welcome, Dr. Mohammed.
Thank you very much. Thank you for the introduction. And it's my honor to be here with you today to present some of the efforts for Saudi Red Crescent Authority employees and also the healthcare system in Saudi Arabia in fighting COVID-19 and also patient safety consideration. Next, please. I would like to start my talk with a letter of appreciation for all healthcare providers and all public health safety officers that they've done many sacrifices to the start of this pandemic when there is no information about the virus and the variant of the virus, how it's distributed. They have made great sacrifices, so I would like to thank all of them. Next, please. I would like to speak about Saudi Red Crescent Authority as an institute, or it have 13 branches in all the regions of Saudi Arabia. Each branch have their individuals, employees, they have their own call centers, and they have their own ambulance station. The next, please. So our services in the Saudi Red Crescent, to elaborate more about what we are doing in Saudi Red Crescent, we are providing the ambulatory services, which an EMS system that we have more than 496 ambulance stations, also more than 7,000 medical care providers in our stations that provide the primary emergency medical care for patients in need and transfer them to suitable nearest medical institute. Next, please. So the other part of our work is also the training. So we are developing healthcare programs for training to the public and also to healthcare provider to raise the level of awareness and skills of your community in the first aid, or also for the healthcare provider how to face such emergency either in homes or in streets or anywhere. Next, please. So also the volunteering is one of our major tasks that have been for the Saudi Red Crescent, and is part of the International Society of Red Cross and Red Crescent. The volunteer is one of our major roles. So we are glad to be one of the first institute in Saudi Arabia to have regulate and have the works for the volunteers to participate in education and training, and also in providing medical first aid to the public, and also to humanitarian relief in disaster and crisis, such as when we were facing the COVID-19 pandemic. Next, please. So, Saudi Red Crescent Authority and COVID-19, how we start to prepare ourselves when we first get the information about the coronavirus that started in China and its risk to reach Saudi Arabia. So as a part of our disaster plan, we have 4 sectors that we are working with: early preparation and quick response and fast recovery, then prevention and mitigation. So as for the early preparation, we started with structuring a team to respond to the COVID-19. Next, please. So this team was formed to plan and respond to the change in coronavirus pandemic. It's as shown here, it have the team leader, the medical direction section that have to write the protocol, specific protocol for the corona, and do the psychological support by its branches. Also to control the infection in our services to ensure patient safety and also employee safety. There is sector for planning, and of course the operation is the major part of our sectors here. It's divided in 2 branches: dispatch rooms and ambulance station services. Also the public information system and the supporting team that have technical support and medical supply also. Next, please. So about the information for coronavirus, in the beginning, there was no clear information about how it's distributed and what's the risk for getting this virus. And it's a major risk for the patients and also for the employees. So there was a panic in the communities and also in healthcare workers. So we have to get the information from the reliable sources to follow up the latest update of coronavirus variants, and also to get them best information to how to deal with it. So our partners, we share the information with them. Next, please. So also as a part of our preparedness and planning, there was a plan for the risk management and business continuity management. We started to get this information and put it as a risk algorithm. Then we have response for each and every risk, and we have the business continuity plan written in Saudi Red Crescent. If there is any major effect, either in infection get out of control, or also if there is infection in our employees that we cannot provide services in certain locations. Next, please. So we did write some protocols, special protocols to respond to these cases, and such as this written protocol. It's in response to the pandemic in triage, and also how to wear the PPE or personal protective equipment, and how to recognize the severe cases at first. So let me elaborate more about this. When there is a call reaching our call centers, 997, if it is one of the major complaints about this coronavirus, which is either there is respiratory problems or there is infection suspicious of this patient, or there is general weakness, we have certain questions to just to see if this patient needs fast ambulance service, or we can divert this call to our partner in 937. So if there is no change in level of consciousness, and there is no chest pain, and if the patient is between the age of 2 years or between 2 years and 60 years, the call will be diverted. If there is any of these before, the answer is yes, the ambulance will be sent as fast as possible because this is a high-risk patient. And if there is no change in liver consciousness and no change in respiratory or chest pain, and the age is less than 2 years or more than 60 years, the call will be diverted to our online medical controllers to assess the case more about it, to see if it is need the ambulance or not. Also, we write the protocol for our employees how to wear the PPE or personal protective equipment in each and every case, and how to do the disinfection and to respond to other patient after we transfer a COVID-19 positive patient or suspected patient. So each protocol have been written in guidance with WIQAI protocols and the Ministry of Health protocol also. Next, please. So our major problems were the human resource. Does we need more human resource if there is increase in cases or there is a defect in our employees that we have infection spreading among them? Yes, there was a risk for that, and part of our assessment that we need to put a plan for this risk. And as shown here, there is if there is increase in cases or decrease of our employees in each region, we have plan for each step to either put more hours on the workers or try to get the volunteers in the ambulance to respond to cases. And thank God there was no need to go to the red 50% increase because the problem was contained before that. Also, the business continuity plan was written for every problem that we have in human resource. Next, please. As I mentioned before, volunteer was one of our main supporter in work during the COVID-19 pandemic, especially in the call centers, which I will talk about it later, but also in early recognition for cases with high temperature or some of the complaints that go with COVID-19 infection. Next, please. Next. Okay. For the call centers, Mr. Khalid was before me talking about the call center in 937. Here we talk about the call center in 997, which is the main call center for emergency, medical emergency in Saudi Arabia. And it was one of our major challenge that there is increase in calls to ask about this pandemic and what to do if there is a patient having some problems. There was no clear complaint that will be asked by the callers, but we have a major rules in this calls that we need to get more and more of it, because there was a drop calls at that time, especially in certain months like April. I will show it later. Next, please. So as I mentioned before, this is the total received call for our CAD system from all provinces in Saudi Arabia. It was usually between 200,000 and 300,000. And like I mentioned before, there was shooting up in the month of April. It reached 800,000 calls in each of our call centers. So we need to get a plan, and we prepared for that before that happening. So we have, next please. We have we established 2 new call centers to respond to this increase in surge capacity for calls, and operated by volunteers and volunteers from medical care provider, or also volunteers from our employees in the call centers. We also have a backup plan to support the dispatcher rooms by the mobile command post dispatcher vehicle, which is shown here. It's called Thuraya. It has the capability to receive the call and dispatch the ambulance from anywhere in the country. So it was part of our plan. We have around 6 vehicles of this like Thuraya. Next, please. So also about the technical solutions that we have or implant in our services, when there is an increase in the calls, we need to have other services that can have the complaint of the patients to access the healthcare system. So the access to healthcare system can be done by this application, which is called Asafni, and it was established before that, from maybe 3 to 4 years before. And actually it have a major role in the COVID-19 pandemic, because when there is increase in capacity in the call centers, we need to divert the calls to the application, so the public can write their complaints in the application, and we respond to that as fast and better than the calls, because we have problems with call centers. Also, we have the collaboration with the Ministry of Interior about the other application to collaborate with Asafni, like Tawakkalna and other applications. Next, please. So there was a performance indicator that we are following daily, because the team that I mentioned before have each day a meeting to see if there is any change in the pandemic, especially in the first few months of the pandemic. So we are following each and every indicator about this, like how fast we are responding to the calls, how long we are responding to the cases to reach the ambulance, or the response time for the ambulance to the case. Also, how our length of stay in the hospital, our timing for the disinfection, and for the ambulance to be back again. Also, we are following some of the clinical KPIs we are providing through our system, because our EBCR, or electronic patient record, it's all electronic, so we can get all information about the cases, and every single information we can just dig in it and think about any way to improve our services. Next, please. So this is also part of our problems. At first, there was a problem with medical supply. So in the Saudi Red Crescent, we have an emergency reserve of medical supply in our regions. Every region have their emergency reserve. And also, when there was a pandemic and actually the blockade of the whole country, we need to get better of our medical supply. So there was a major role in that, and the planning and collaboration with the other ministries for this was having a major role in our work. Next, please. Also, we need to focus on our employees, because they are the first responder to the scene. They have their own issues about they fear the infection at first. We have to elaborate more about their resilience to infection, we do some positive messages to them, and we are doing psychological support 24/7 for them to support if there is any fear of distribution infection to their families, their lovers, or their community also. So also to ensure the safety behavior they are doing in responding to these cases. To ensure the patient safety for that, we are doing a major role in training them and also the infection control protocols to be done every month. Actually, we are reviewing the protocols to see if there is any change in it. Next, please. So also the public was one of our targets to increase their knowledge about the infection about the coronavirus. So we have our program to make sure the safety through knowledge initiative was done. We have more than 500,000 individuals that have been benefit from our training courses. As you can see here, the infection control was one of our major training courses that have been requested by the public and also by healthcare providers. Disaster management was the second. Also, there is a life ambassador, airway management, occupational safety, and first aid for first responder, and other programs like volunteering principles and like such. Next, please. So this is for our experience in Great Crescent. I hope you enjoyed it. Thank you very much.
Thank you very much, Dr. Mohammed, for this presentation and for clarifying the role of Red Crescent. We would like to go to our next speaker, Dr. Dalia Mu'min Khan, the CEO, National Health Command Center at the Ministry of Health. Welcome, Dr. Dalia.
Welcome, يعطيكم العافية. So, good morning, everybody. I am Dr. Dalia Khan, the CEO of the National Health Command Center. First, I would like to thank you, Dr. Yasser, and your team for giving us this opportunity to give an overview and some of the efforts that the NHCC worked and held the kingdom during the pandemic. Next, please. So what is the NHCC? The NHCC is, the previous page, please. It's the National Health Command Center. The NHCC was launched at October 2019, and it was just before the announcement of the pandemic internationally. Why was the NHCC launched, and what was the main purpose of having the NHCC or the National Health Command Center? So the NHCC main purpose is to support the decision makers by giving them a comprehensive view and 360 degrees understanding of what's happening in the health, giving all the pieces of the puzzle and ensuring that the health system performance is up to the standard that our decision makers would like to see it. Next, please. So our unique model in the National Health Command Center and in working in the center is one of the main successes of the center. So what is our model and what is the difference in this model between in the NHCC and between our previous way of operating? Usually we used to see things vertically, so in silos, and having those verticals did not give the full understanding of the whole processes. So in the center, we do observe and analyze, and then we do auditing on those observations. We do the intervention after that, and after the intervention, we do the monitoring, but it's not a regular monitoring, it's more of a proactive way of intervention, a proactive way of monitoring. Next, please. During the pandemic, NHCC started again at 2019, and by March 2020, we had the first COVID case in the kingdom. the operation was not, we didn't know what are we expecting, and we didn't know what are the numbers that we are solving for. Some of the issues started from day one of the operation. Of the operation to fight COVID. For example, from those operation centers that are listed in front of you, the Laboratory Operation Center. So in the beginning of the pandemic, we all know that we needed the PCR testing results. And those testing results were taking a long time in the turnaround time. We had limited amount of labs, and we had limited resources in those labs at that time. So if a PCR test took 72 hours to have the result, that was a good achievement at that time. We're talking about the result from taking the samples until having the result to the patient's hand. With the Laboratory Operation Center, it started as an operation room. It started with 5 to 6 team members, and those members were solving to decrease the turnaround time. The NHCC support is by bringing different teams, bringing the main stakeholders, bringing the analytics they need to be proactively to managing the laboratory and the PCR testing turnaround time. And within a couple of months, we decreased from 72 hours to 24 hours to 16 hours, and we reached up to 14 hours turnaround time. So we solved different complex operation. We're talking about the logistics. We're talking about the sites of the testing and collection of the samples. We're talking about the transportation of those samples, as well as the labs themselves, the kits, the handling of those samples, the human resources there, and the training of those human resources. Another center or another incubation that happened was the Immunization Operation Center. We all know that with having the vaccination for the COVAX, the challenge was how can we ensure that all the population have access to the vaccination, and how this vaccination is being accessed at the right place at the right time with the right transportation and handling of the vaccine, in the training of the resources, in the ensuring that the population are aware, they know how to reach us. So in the Immunization Operation Center, again, as an incubation, it started as a team. It started as an idea. Should this idea continue to be an operation center, or should this idea continue to launch a separate business as usual path and department, or is it just some efforts that we need to launch a system and then everybody would go back home? But actually, with the Immunization Operation Center, we knew that this small team would go to have a full operation center and the integration between those centers and different centers. So we were solving to have the access per population. We're not talking about the average in the kingdom. We're talking even for the average of the regions, the average of the city. We were solving the supply-demand issues. How those immune or vaccination are reaching to the regions. And this is not the effort of the NHCC team. And again, we say that NHCC is incubating the ideas and it's supporting and launching them. So we have a multidisciplinary team from the public health, from Wiqaya, the CDC, from the logistics, from the supply chain team, and many other teams in the ministry, just to ensure that this vaccination is reaching to everybody. Next, please. So again, the operation model in the NHCC helped in doing or in supporting many of the operation centers. This model is by observing analysis, and then we support decisions. Either we do the intervention on a small scale, or this intervention would be ticketed to the region. And what I mean by the ticket is telling the stakeholders in the region, telling the hospital, telling the PHC that you have a certain point that you need to improve. And this improvement, either it's done by the region or the institute itself, or it would be escalated. So we have built a well-structured escalation matrix, a well-structured RACI matrices, and those matrices are giving the network between different operation centers. Some of the issues would be observed, analyzed, and ticketed, and then the escalation would show us that multidisciplinary team should work on that topic. Supporting the decisions and giving the right decision at the right time is a very important aspect in our operation, and as well the continuous monitoring. So we want to ensure that what we solved for is kind of improving in our process and improving the outcomes, rather than solving for an issue in one region and still showing that issue in another region. So generalizing the solutions among the operation on different regions. In the center, we issued more than 200 case tickets, and for each of those tickets, we have a way that we can identify where is the trigger or the alert in each of the operation centers. And this alert would reach to the region, would reach to the PHC or to the hospital, to the certain department we are dealing with within the emergency department. It's the supply chain team in the region, or other teams. And the feedback from the regions is the closure of those tickets. We don't only solve by closing the tickets, we audit and we ensure the closure of the good quality of those tickets. Next, please. So in the NHCC, or the National Health Command Center, we do analyze the data to support different operation centers. We have different ways of analyzing data. We start by analyzing the descriptive data to understand what is the process, to give the full description to the leaders of the status quo of the processes. And then we go to the diagnostic analysis and the simulation and the advanced prescriptive analysis. In the simulation with the COVID, we had multiple scenarios and use cases that we worked on. We worked on regional level on the expected number of cases, and those simulations were accurate up to 95 and reached 98% accuracy in some of the regions. And by that, we can know what are the demand in the region in advance. So we are ready instead that we are reactively dealing with the pandemic. We had simulation as well, and we supported the Kingdom in the simulation for the Hajj of 2022, as well as the simulation and prediction that is happening with the vaccination program, and what is the time frame that we're expecting to cover the population, or what is the percentage of each age group, or the percentage of each different risk groups in vaccination. Next, please. With all those efforts, we are measuring our impact. Our impact is not only financial impact. Yes, it is important to measure the financial impact and the efficiency and cost saving, but it's not the most important impact. We usually see it, and we ensure that we are looking at the impact from the patient safety perspective, from the impact of how many, the saving of lives. We ensure that we saved thousands of lives. We ensured that we improved the quality of life for the population. And this is the major impact that we are looking for. It's our major outcome we are dealing for. It's the health of the population and the health of the human being. And our impact from the financial perspective is supporting a lot in telling how this way of operation and this model is successful, and it can be replicated in different use cases and different scenarios. Next, please. The National Health Command Center, and during the pandemic, had the secretary of the COVID executive committee in the ministry, which is the major and the main committee headed by His Excellency the Vice Minister, and having the platforms from different deputies in the ministry to ensure the networking is done in the best way, and the process is performed in the way that it should be done. So we have different platforms in this committee. We have the Immunization Platform, the Data and Digital Platform that is solving for all the data related to the patients and the population, and their vaccination, their PCR testing results, and how is this be structured and easily accessible upon the need for the decision makers and for the population as well. We have the supply chain platform, and that platform started by monitoring the availability of the PPEs in the hospitals and in different sites, and it expanded to cover for the immunization, to cover for the medication needed, and to cover for the logistics for the laboratory and other medications and consumables needed. We're talking about the compliance platform to ensure all the health system is compliant with our standards. The communication platform, the media, the financial, the CCC, which is the public health platform with the support of Wiqaya, the CDC in the kingdom. The National Health Emergency Operation Center, and the genetic sequence platform. This executive committee is headed again by His Excellency, and the performance in this committee supported a lot the decision makers in the ministry in succeeding in fighting this COVID pandemic. Next, please. The National Health Command Center as well was monitoring the recovery plan. All of us know that with the beginning of COVID pandemic, many routine services were paused, in whether we're talking about the operation rooms, the OPD, the clinics, the admission for elective surgeries and day and routine surgeries, and as well as some of the laboratory and specialized centers. So in the recovery plan, we're ensuring that the system is recovering in the best way according to the level of the pandemic level in each region, and how can we open or reopen those routine cases and go back to our baseline or better than our baseline. The 80% that we see here is the achievement of the recovery by the end of Q3 2021. Actually, by the end of 2021, we exceeded 90% of recovery of the routine services in the kingdom, alhamdulillah. Thank you, everybody. Again, this is the National Health Command Center, and we supported, we incubate different ideas. Either this incubation would end by having an operation center, by launching a special system, or by having an issue solved, and we ensure that those issues are not repeated. We help in proactively support decision makers by analyzing data in advanced analysis way. Thank you, everybody, for listening to us today. And if you have any question, you are welcome.
Thank you. Thank you very much, Dr. Dalia, for this presentation. We really appreciate it. We would like to go to our next speaker, Dr. Khalid Ibrahim Abdul. He is the Assistant Deputy Minister for Primary Health Care at the Ministry of Health. Welcome, Dr. Khalid.
Good morning, everybody. Thank you for having the chance to present about the experience in primary care during the pandemic and all the other activities happened during that. Today, I believe we learned a lot from different experience and it's reflecting the successful plan done in the Kingdom of Saudi Arabia, where can say the pandemic didn't affect the kingdom massively, and we could reach a good, or let's say, a very high number of coverage in vaccination. If we can start with the first slide, please. In the healthcare system, we know that in Kingdom Saudi Arabia, we have a universal health coverage, and all citizens are eligible to get the treatment in the MOH facilities. And the citizens about 22 million. And that's why in the primary healthcare, we have a network of PHCs where receive all, let's say, citizens and eligible expats in our centers. Next slide. We are going in a transformation in the health sector, and during the pandemic, it was, we're in the middle of the transformation that might affect, the transformation, but at the same time, some risk might exist during the alignment and the transformation mode. We were in the middle, but I believe the pandemic was really helpful to expedite a lot of activities and investments that helped us now when we resume the transformation. Next. Before the first case, we're trying to be always ready in our network of primary healthcare centers, which is about 2,300 BHCs in all regions in the kingdom. So next. In order to be ready, we designed a pathway how to isolate any suspected case attending to the primary care and giving the chance that we might pick the first case in a primary care center and to have a very clear pathway for referral. We were checking the readiness by providing the supply, and we installed an assessment tool that now we are using widely in the primary healthcare. We call it Musta'id. This assessment tool used in the morning huddle, where they go through all the items needed during the day. We also use the audit systems using a mystery shopper and visiting the primary healthcare to make sure about the readiness. Next. After the discovery of the first case, we know that we went in a lockdown, and we start receiving cases to do the treatment. On the same time, there was screening, contact tracing. Even we went to the mass testing to discover any early outbreak in the community. Then at the end of the pandemic, we reached to the vaccination, where the primary care contributed in the vaccination. Next. The mass testing, and I was in charge of the mass testing in the beginning, was to detect the early outbreaks. So when we screen more, it means that we identify more, isolate more. So we break the chain of transmission, and this will break the number of cases expected that's going to load the healthcare system. We believe with having these mass testing sites, having and increasing the capacity of testing, we could contribute in identifying and isolating the cases very quickly. Next. In the mass testing, we started in March to do the active target surveillance in the crowded area or in the areas that we suspect there is an outbreak. Then we start doing a high-risk screening based on the facts of the outbreaks in certain groups. Then we installed what we call it TACID centers. It's drive-through centers where we have the testing starting from making an appointment through a digital solution with a very, let's say, a digital journey from taking the appointment, you get the barcode and you get tested at the center, and your sample will be linked to your ID, and you will get the result on your phone again. Next. We used a mega drive-through centers, many drive-through centers, and we use the primary care as well as hubs for mass testing. Here, we just received anyone who contacted a sick patient, for those with symptoms, usually they go to seek medical attention at the primary care on the hospital. Next. TACID centers were like this. We reached to 23 centers all over the kingdom. It accommodates thousands of customers per day, and we're following every day the performance and following the results and the positivity from these centers, and it helped a lot. Usually we detect the first outbreak or wave in a certain region by increased demand on these centers, then increased positivity. It followed by symptomatic cases coming to the primary care or hospitals, followed by more admission, and then ICU admission and deaths. Next. In June, we felt that there was a pressure on hospitals. People were really panicking, a lot of people complaining from symptoms, cases were increasing. So the decision was to open what we call it fever clinic, and we call it Tadamman clinic. It means rest assured. So we opened 238 clinics, were rolled out in 5 days in existing primary care centers or peripheral hospitals with very clear protocol. And there was a daily readiness checklist leveraging the Musta'id tool to make sure that everything is ready, and on daily monitoring, and we monitor the cases on daily basis. Next. These clinics, it shows the number of visits, number of tests every day, and even the referral rate. We reach until now more than 5 million visits to these fever clinics, and these fever clinics helped a lot to relieve the health system and to relieve the emergency rooms. And we can see the trends in visiting these clinics. It comes always and give a hint if there is any increase or wave in a certain or particular region. The referral rate to the hospital for those who need further medical attention was less than 2% of the visits we received in these clinics. Next. In vaccination program, when it is arrived to Saudi Arabia, and we started actually in December, the 17th of December 2022, and Kingdom of Saudi Arabia was one of the first countries to start giving the vaccine. We had very clear strategy to have a coverage of more than 70% of the population, to have very clear access to all citizens and residents. And this reminds me by mentioning that the fever clinics and mass testing clinics was open for everyone, all citizens, all residents, and even for illegal residents. Going to the operation as well, back to the vaccination, we were really concerned about the quality and about the experience. So we were really focusing to have a better quality and experience for the visitors, as well as to leverage the digital solutions on using the vaccination registry, where we could now use all of these data to identify the vaccination status, and using this as well to reach more people to get the vaccine. Next. We started with priority groups, then we opened for all the community. Next. Next, please. We were usually monitoring, and we planned per quarter what is the target population that we need to reach based on the supply we expect from the vaccines, as well as considering always the priority groups. Next. We were following and monitoring through the Immunization Operation Center, which is part of the National Health Command and Control Center. And I believe Dr. Dalia, she mentioned more about the operation in these centers and using the ticketing system as a language between the central team and the regions, where we monitor in different verticals, the governance, supply chain, operations, digital, communication, clinical quality assurance and patient experience, and we release tickets accordingly. Next. We had different vaccines in different places. We had mega sites, and we had used like some expo sites, some airports, any area that we could accommodate good numbers, as well as we utilize the existing hospital and BHCs. Next. These are examples of the sites that we use. Even the drive-through was used in vaccination. Next. We had SOPs for all activities related in the vaccine. So it was shared with all stakeholders, with all practitioners to follow the instructions. And we paid attention as well, even of training. And we had a platform for that. Next. This is the training materials and online materials that was shared with staff, and we were following the training and getting the clearance to start giving the vaccine in certain or particular sites. Next. This is example of the courses, the online courses we had. Next. Supply chain was the biggest always challenge with the cold chain, maintaining vaccine in the accurate or the proper temperature, having a temperature log, as well as having this associated items in place in every outlet. It was monitored carefully on daily basis with daily reports, starting the day and ending the day. All of these items were observed, and I can tell we couldn't or we never had a major challenges shutting down BHC, shutting down a vaccination center because of lack of these items. And even the appointment was really matched based on the capacity that we have for every supply item. Next. So the supply was monitored carefully through a dashboards and ticketing systems. Next. Digital solutions, it was from the, let's say, the population side, where they use صحتي app and تأكد توكلنا app to book an appointment, given the choice to select the nearby center, and they go to take the appointment, and the vaccination status will be registered for them in the app, while we were registering the vaccination as well in the National Vaccination Registry, where we could have all the data provided, and we know exactly our performance, our needs for supply, and how to reach our targets, the performance from region to region, and to simulate reaching to our target and coverage. Next. It was end-to-end digital journey, starting from the appointment to the arrival to register the vaccine, as well as monitoring the supply needed, and even the clinical outcome or any side effects was recorded in a digital system. Next. The communication was very important. We had a communication plan with the community to encourage people, especially the high-risk groups, to get the vaccine. On the same time, we were paying attention to the customer experience. There was survey usually sent to customers once they finish getting the vaccine in the vaccination center, and according to their response, we do our corrective actions to make sure that the vaccines are given in the proper time. Next. We could say that the vaccine centers were achieving a high or the good, let's say, ranking in customer experience in comparison to all other existing services. And it was really something that we feel proud that we could reach a good coverage with a good service in terms of quality and experience. Next. This is all for today, and thank you for this opportunity.
Thank you very much, Dr. Khalid, for this presentation. We would like to go to our next presenter. Mr. Ali Shahrani is the Executive Director of Pharmacovigilance in the Saudi Food and Drug Authority since 2018. He completed a master's degree in the pharmacology from King Saud University. He received a postgraduate certificate in pharmacoepidemiology and pharmacovigilance from the London School of Hygiene and Tropical Medicine in the United Kingdom. Welcome, Mr. Ali.
Thank you, Lamia, and thank you for everyone. I would like to thank the Patient Safety Center for inviting us to participate in this important event, and thank you for the organizing champions. I will start my presentation with the outline, so please next slide. This is my outline. I will talk about overview on the experience with the CFDA that's in terms of vaccine approval and reporting, and then we will move to the regulatory approval and licensing pathways, and we will have some information about the comparison between the COVID-19 vaccine and the standard vaccines. One of them is about the regulatory standards. Then we will talk about the approval status of COVID-19 vaccines and other treatments. And we will have brief information about shipping requirement and what we have learned from the experience of the SFDA. So next slide, please. As you know, and based on the establishment law of the SFDA is responsible for registration of the all medicinal products, including the vaccines. So in the beginning of the pandemic, the Saudi Food and Drug Authority started to screening all literature and other health regulatory agencies to seek if there is any promising treatment or vaccines that will help in the elimination of this pandemic. So the SFDA open direct communication with the companies, with the regulatory agencies worldwide, and with other some associations and councils, and some aligned with the SFDA. So also we have communicated with other pharmaceutical companies that have promising vaccines, and to seek their if there is any obstacles or if there is a need for arrangement of application procedure. Next slide, please. One of the most important issues that have been considered during the submission of the files from the marketing authorization holder or from the manufacturers to the Saudi Food and Drug Authority, the uncompleted data of the submission files during the starting the campaign of manufacturing those vaccines. So we communicate with the companies to notify them that we have a new guideline about the rolling submission that have been in place as internal process to receive the vaccine and treatment file in the from the beginning of the clinical studies, and to follow up with the company until the file is completed. And actually, this procedure has made it easier to study the vaccine and treatment data quickly and efficiently. Next slide, please. So this is the guideline for rolling submission, and actually it's just a technique that considered as ad hoc procedure, which is used to allow the SFDA to continuously assess the data for an upcoming highly promising medicinal product as they become available, and the companies can provide us with the data, with the available data as soon as that possible. And this will help us to review the files once they release from the company. And the rolling submission can accelerate every step of the regulatory pathway and leading to finalization of the approval process much earlier than with other type of review. So we release this guideline to the companies to allow them to provide us with the data as soon as possible. Next slide, please. What we have also considered to overcome the problems that may be considered during the submission of the files, we create working groups of experts in different areas, from infectious disease experts in the pharmacoepidemiology, and also in the clinical trial experts from all scientific departments within the SFDA. And we have also experts from the different regulatory agencies worldwide. And also we have some experts from the hospitals and from academia. And we also continue the meetings to discuss the up-to-date status of the vaccines and treatment worldwide. And actually we have at least meetings every 2 days to discuss the up-to-date information about those vaccines and their status worldwide. And also we have to share a daily report for the status of all vaccines or treatment to be distributed to all experts to discuss the status of those vaccines. Next slide, please. So, as I mentioned before, the vaccine manufacturer should apply the file to the SFDA seeking the approval of the SFDA. And as we know, during the pandemic, there is a lot of regulatory agencies provide an emergency use for the vaccines, and in the SFDA we have the similar issue, but we have the conditional approval for those vaccines, which enable the companies to temporarily authorize the supply of uncompleted registered medicinal product in response to certain identified public health risks, such as the COVID-19 pandemic. And after the submission of the file or available data, the SFDA will assess this data in terms of safety, quality, and efficacy, and will consider the same level of scrutiny as the usual licensing process. And this exception is only used when strictly necessary to speed up the process to provide an access to a potential life-saving product. Next slide, please. So here is a diagram about the regulatory approval and licensing of the vaccines, and it covers all phases that have been considered during the submission of the file for approval in the SFDA, and it covers the development, evaluation, and approval and monitoring of those vaccines from the manufacturer until the availability for use for the subjects. So as you can see here, there is a section for pharmaceutical or first stages about the pharmaceutical quality, and here the Saudi Food and Drug Authority have to ask the companies to submit the studies that generated to data to on vaccine component and their purities, and about the biological activities, and some data on each steps of manufacturing, how they manufacture those vaccines, and also the data on the controls used to ensure that each batch of the vaccines consistently of good quality. And by the way, the storing conditions for those vaccines. The next one is about the clinical trials, and the companies is asked by the SFDA to provide laboratory data before the testing of those vaccines in humans. To enable the SFDA to study the types of immune response that have been released, can identify the potential safety problems, and to make sure that the vaccine does not cause any fertility problems or not affect the baby's development before the birth. Also to check if the animal given COVID-19 vaccine are protected from the disease when exported to the virus and not worsening the disease, and we call this challenge studies check, and sometimes to have a good knowledge about how the vaccine reaches the body organs. And the next phase, which is about the clinical trials, and we have different phases of the clinical trials, but in this phase, we have studies in human to have a clear image about the safety, efficacy, and immunogenicity about those vaccines. And actually, all clinical trials follow strict scientific and ethical rules. And during these clinical trials, we have different subjects that have been enrolled for each phases, and there is some measures that have been considered in each measure. So after that, once the companies provide us with the data that have been available during the development in the 3 phases, we have a robust and highly qualified teams that have been involved in the evaluation of those files in terms of quality, safety, non-clinical, and clinical. And after that, they present those data to advisory committee, which have more than 13 specialists in the infectious disease. And after that, it will be presented with details in the advisory and the essential committee, which is responsible for releasing a decision about the conditional approval of those vaccines. And then after that, the company will be communicated to provide them with a certificate for conditional approval to allow them to start the scale up of the vaccine, which is the phase of manufacturing. After that, the Saudi Food and Drug Authority will start the monitoring of the safety profile in the post-marketing phase with regard to the different aspects of safety monitoring, like passive, through collaboration with other stakeholders such as Ministry of Health and other health sectors to receive the adverse event following immunizations and to analyze them and see if there is any risk can be captured during these phases. And we have to collect data through the active surveillance programs, through some registries and some surveys. So next slide, please. Next slide. What's the comparison between the COVID-19 vaccine and the standard vaccine in terms of evaluation? With regard to this, the regulatory standards, there is no difference between those vaccines, but during the pandemic, we have to make the evaluation process as shortest as possible to make those vaccines available for use. So as you can see in the first, in the above diagram, there is the flow of the registration pathway as indicative timeline for the regulatory or for the regular vaccines. As you can see here, the evaluation process by the Saudi Food and Drug Authority can be started after the submission of all data related to the clinical trial phase. But during the for the COVID-19 vaccines, we can start the evaluation of the file during the conduction of those clinical trials to expedite the evaluation of those vaccines and to make them available as soon as possible. So during the pandemic, the SFDA started earlier than usual to make the proper decision in the shortest needed time, and the COVID-19 vaccine development is compressed in time, applying the extensive current knowledge in the vaccine development. And as you can see from the timeline, there is a difference in sometimes in the regular vaccines, we have more than 100 working days to make those vaccines available. But during the pandemic, once we have all data, we have about 14 days to have the decision about those vaccines. Next slide, please. So as I mentioned before, with regard to the regulatory standards, there is no difference, and all vaccines must be approved according to the same standards that applies to all medicines in the Saudi Food and Drug Authority. So there is no difference with regard to the regulatory standards in terms of safety, quality, and efficacy. Next slide. This is the registration status. Actually, we have received 15 files related to the vaccines, COVID-19 vaccines and the treatments that have been designed to treat the COVID-19. Of those 15, we have 8 vaccine application. Next slide, please. So as you can see here, we have the vaccines and the treatment, and today we are talking about the vaccines. So we have 4 vaccines approved right now, and we have 3 vaccines under evaluation. We have Pfizer and Moderna, as you know, it's a messenger RNA, which is use the genetic information or instruction to release the immune response or making the immune response against the COVID-19 virus. And we have Janssen and the ARCOV, which is viral vector that use modified adenovirus platform for making to carry the genetic instruction to release or making immune response against the coronavirus. Next slide, please. One of the most important issues during the pandemic, which is or during the evaluation of the vaccines, that we have a great infrastructure for collaboration with other international agencies, such as the International Conference of Immunization, which is responsible for making the guidelines for submission of the files and the standards that have been considered by the regulatory agencies. So we are a member of the 13 countries worldwide, and we have been involved in the setting the guideline for submission of different types of medicines. And also we joined the International Coalition of Medicine Regulatory Authorities, which helped a lot during the evaluation of the COVID-19 vaccine in terms of data sharing and exchange with regard to the efficacy, quality, safety, and those vaccines. Next slide. This is the shipping requirement. Actually, the Saudi Food and Drug Authority supervises the shipping of those vaccines through releasing the guideline that's related to the good distribution practices, which illustrate all information that's required for shipping those vaccines and other medicinal products that can help in the evaluation or maintaining the storage condition and the temperature and etc. And as you can see here, there is some picture of handling those shipments. The next slide, please. We have learned a lot from the pandemic and from the evaluation of those vaccines, that we have a great IT infrastructure that help us to communicate with the companies, to sometimes conduct some remote inspection for the manufacturers of those vaccines, and to have a lot of online meetings with the companies either inside Saudi Arabia or outside Saudi Arabia with the headquarters. And also we have also the good infrastructure help us to expedite the evaluation process through the remote working. One of the most important issues that is the collaboration with other stakeholders, either locally or internationally, is crucial, and pooling expert is very important in such situations. And invest more in the staff member scientific knowledge and skills should be considered, and should be a continuous process to accommodate the changes and the development of the vaccines, new vaccines platforms, and etc. And the regulatory framework should be studied periodically and should be flexible to accommodate the changes that may be happened by the such pandemics. Thank you again for listening, and Lamia, the floor is yours.
Thank you very much, Mr. Ali, and thank you, Saudi FDA, for this journey during COVID-19. We'd like to go to our next speaker, Dr. Abdul Aziz Alhamud. He is a physician informatics who is currently working as the medical director for the virtual hospital. He is an emergency consultant at King Fahd Medical City. Welcome, Dr. Abdul Aziz. Dr. Abdul Aziz, your mic is muted.
Thank you, Lamia. Thank you so much for everybody. It's so good to be here with you guys with quite a few popular faces. You worked tirelessly over the last few years to shape the country's response to COVID. Today, I'll speak briefly about the Digital Health Center of Excellence experience, what we were doing since the beginning of the pandemic and moving forward. Can we move to the next slide, please? Yeah, so in the third quarter of 2020, the Ministry of Health, as part of many initiatives that they had, they wanted to build a digital health center of excellence. And because of this situation, even before COVID, the prevalence of diseases, whether it's lifestyle-related diseases or communicable diseases, were increasing. The geographic barrier between healthcare organizations, experts, and end user, customers or patients is huge. The workforce gap continues to be there, especially when it comes to experts in specific fields or some of the surgical specialties. The cost is still, it's there, even with technologies. Whenever we add more technology, emergency, electronic health records, data analytics, all these tools come with costs that also become an impact to the already expensive service. The awareness with health disparity and health security risk, a lot of people and organizations and nations now look at health disparities and health security risk as a real challenge that has to be taken into consideration. Plus COVID, all these conditions pushed for the team here, the Ministry of Health, to work on building the Digital Health Center of Excellence. Can we move to the next slide, please? The main role for the Digital Health Center of Excellence is to basically make digital health available, promote digital health, work with regulatory bodies, build partnership, invest in building human capability, make sure there is a way for knowledge transfer between experts. In Saudi, we have few organizations with deep experience in utilizing technology and utilizing digital health in a couple of initiatives since even the 90s. If you go over a couple of publications, you would see the need and awareness of the value that digital health could provide for care. It's been around. So one of the things that we was core in our role was to work with knowledge transfer. In addition to building the right medium for innovation, artificial intelligence, machine learning, natural language processes, and more and extra kind of tools that really fall into the big data analytics. Can we move to the next slide? Yeah, our map, since the beginning, we had a clear vision where we had started with virtual clinic, and I'm sure a lot of people around here, whether they either used it, they provide care to patients using virtual clinic, or they've seen or heard from their patients the value of virtual clinic. We worked with digital partners and other groups within MOH and the Ministry of Communication to work on the infrastructure and then enable the ability to use virtual clinic. The major goal for us was to train everybody, make sure all organizations has enough infrastructure, work with patients and population to accept the value of, to accept the use of virtual care and measure their satisfaction. Right after we completed the virtual clinic program, we took it to an extra notch, and we tried to build the right collaboration between different organizations in Saudi, initially focused on MOH and expanded to other healthcare providers. We built the virtual referral program, which focuses on providing access to experts remotely within at a regional level. And the third step, which is one of the biggest one, is the Sahara Virtual Hospital, where we had the inauguration a few days ago. The last step will be the Artificial Intelligence Lab, and we'll talk about it. Can you please move to the next slide? Yeah, here are some of the numbers. I wanted to take you with us through the journey from day one. When we started with the virtual clinics, we had dismal numbers. We had less than 1,000 number at the first month. I worked really hard on change management, engagement, process improvement, and reaching out to everybody, reaching out to physicians, reaching out to stakeholders, reaching out to patients. And today, we are heading more than 500,000 appointments per month. The last one in this graph is from last November, and we're at 300K per month. This came with a package. Let's go to the next slide and share with you some of the issues that we face. Can you please move to the next slide? Yeah. So when we started the virtual clinic concept, given that it went through some sort of governance and regulatory evaluation, it's not as simple as the usual kind of easy ad hoc tool that you could download. We had, and I'm sure the MOH experts here know the regulatory process that we have to go through. We initially, the patient no-show was a huge challenge, and we didn't put it on our partners or patients. No, we looked at the process from many aspects. We did a lot of analytics and came up with targeted change management protocols, trying to help with that. And luckily, we dropped it from almost 70% to now to less than to almost 50%. This is last year, and now we're hitting, we broke the 50% gap. Can you please move to the next slide? The work is not only technology, it's also people and management. So this is how, this is the acceptance rate of facilities and organization across the kingdom when it comes to adopting virtual clinics and making it part of their usual daily practice, part of their patient care management protocols, part of the journey. We reached to almost 1,300 facilities today, is completely live with the virtual clinic system. We started by less than 40, and now we're at 1,300. Can you please move to the next slide? Yeah. Then the next project was the virtual. Let's just see. No, this is for physician adoption. So yeah, for physicians, again, making sure your physician go through the training, making sure your physician complying with all the regulation. We're using this tool, and I'm sure majority of you guys have it. And the advantages of having such a unified platform came handy to us when it comes to tracking physician licensing, tracking who's active, and we're working really hard with other parties in Saudi to make sure our physicians maintaining their license and what's required for them to practice medicine in Saudi. Can we move to the next slide, please? Yeah, the next phase was the introduction of virtual referrals. Again, one of the things that sometimes we see when it comes to getting patient access to care between multiple organizations is the fragmented care and the gap in the journey. So the virtual referral program wanted to really push patient who doesn't need to go through this hassle to get the access to the virtual mind or the virtual expert, the virtual specialized expert, while they're still within their hub, within their organization, within their home, without the need for travel. And I'm sure we all know the challenge that comes with travel, not only for the patient, but the patient and family. And the core kind of goal of the virtual referral program, which is relatively different than the virtual clinic, is to contain patients within their location, making sure that they're comfortable with their people, making sure that their primary physician is aware, completely connected with the team without going through that trouble. Can you please move to the next slide? Yeah. The adoption, the acceptance, the utilization is across the kingdom. Almost every region is there. Every region is looking at this tool as an active addition to their service. We really want to make sure, again, the health disparity is not there. We want to make sure people in the north, in the south, different ages, different conditions, different limitation, whether it's speech, voice, or whatnot. It's all taken into consideration. This is a core for our work, making sure that we are across the continuum, across the whole group. We're not only for sophisticated people, we're not only for the Z generation or people who are connected to their phone all the time. We want it to be available for the whole population. Can you please move to the next slide? Yeah, this week we launched Sahara Virtual Hospital, which is one of the initiatives hosted by the Digital Health Center of Excellence. The Sahara Virtual Hospital provides a clear example of the power of collaboration. This is the Minister of Health, the Minister of Communication, and the National Health Authority, Digital Authority in Saudi. The three groups worked really hard, in addition to connecting with partners at MOH to build the virtual hospital or Sahara Virtual Hospital. We went live officially this week, but the work started almost a year ago. Can you please move to the next slide? Next slide, please. Yeah. When we kind of built that project, the things that came across our mind and things that's always in front of our mind are these major goals. We want to provide access to care. Access should not be an issue. Every hospital at MOH that are part of this project has to have access to our expert. Using access will help us expand clinical excellence. We want to enhance the experience, not only for patient, for healthcare provider, because again, when it comes to pandemics or issues like that, you want to make sure your providers, healthcare workers are going through the perfect experience possible. Knowledge transfer. We have few experts here who, when they communicate with their patient, I want to make sure this knowledge continues to transfer. We're looking at this as an unusual knowledge transfer training education medium. And definitely we wanted to drive better outcome. Can you please move to the next slide? Yeah, it wasn't easy. We had to go through many projects, and I didn't want to share a lot of details because it's mind-blowing, but briefly, one of the three major steps that I wanted to share with you guys is the benchmarking effort that we had to go through. Having a virtual unit or a virtual hospital that's a standalone is an innovative idea. It's been around, but such a scale with tons of specialties and with without being part or hosted within a healthcare organization is a unique concept. One of the organizations in the US has done something similar, and still nothing with this scale, nothing with hundreds of hospitals, nothing with such a breadth of conditions or services, whether it's acute or critical or home base or whatnot. In addition to that, the commissioning, to launch a hospital, a virtual hospital, you have to go through a commissioning process. That wasn't easy. It took us almost a year to know that we are complying with the MOH regulations and regulations that governs any hospital. For each service that we provide, we go through a national committee that evaluate the specialty, look at the demand assessment, what do we want to achieve, how are we going to provide better outcome, what's the KPI, what's the expansion process, what's the recruitment, what's your strategy, and what's your contribution to healthcare in general. Can you please move to the next slide? Yeah, today, again, we're connected with 130 hospitals across Saudi. We have almost 50 specialized providers. Majority of our staff are with advanced training, with long experience. They're the ones that you look for if you want an expert opinion. We recruited them from the Ministry of Health, from other partners, universities, and name it. And an expert was part of a majority of the people who actually built that are experts and have a reputation within the field. We have almost 9 main specialties with more than 25 subspecialties. Can you please move to the next slide? These are just briefly the number of specialties and subspecialties that we either have or in the process of finalizing the implementation. Next slide, please. The theme of services that we provide is divided into these major kind of themes. We started with outpatient specialized clinic because the need is huge. The waiting time is not in days. And our waiting time is 7 days today for any specialized clinic or referral. We then supplemented that with acute virtual consultation at a very structured process. The hospital has to be built. The on-call need to know what's the escalation process, who is the first on call, who is the response, what's the update, how to communicate with. And this work is completely aligned with other partners, with the National Referral Center, with the Lifeline, and other partners in MOH and across the globe, across the continuum. We have a few multidisciplinary teams. One of the things that I wanted to highlight is the virtual heart team, which is one of a kind, where we collect almost 8 specialized cardiologists, cardiac surgeons, structural heart disease and whatnot, and they sit down and receive advanced requests from the heart centers across in Saudi. We also started with a few home-based care. And one of the recent initiatives that we went live with was the acute care hospital at home, trying to ease the burden on hospital beds. And we wanted to make sure that all aspects of healthcare is here. Radiology, pathology, pharmaceutical therapies are completely part of this. That's what I have for today. I'm happy to hear your questions. Thank you so much.
Thank you very much, Dr. Abdul Aziz. Amazing presentation. Hope our audience benefit from that. Thank you very much. We will go to our next presentation done by Dr. Muhammad Arafat, the Executive Director of Medical Services in Medical Referral Center at Ministry of Health. He is an emergency medicine consultant from King Saud University in Riyadh. He has the Saudi Board of Emergency Medicine working in King Faisal Specialist Hospital, and he has a business and administration postgraduate degree from University of Manchester, UK. Welcome, Dr. Muhammad.
Assalamu alaikum. Thank you, Lamia. Welcome, everyone. First of all, thank you for attending this. Thank you for giving me this chance to be with you guys here. Speaking about our experience and the national efforts fighting COVID pandemic in Saudi Arabia is something that we're proud of. What we achieved, what we reached is something that people are talking about through the universe. And thankfully this was most of it, all of it, because our secondary to the support and the work and the collaboration between every single entity within the country. So talking about Saudi Medical Appointments and Referral Center, can you go to the next? Yes. So our center was initiated or started at 2017 when we gathered few areas, few different departments, different small management and departments in different places in the ministry. So we covered initially medical evacuation services, also medical medical appointments and referrals, and bed management department. So going to the next slide, please. SMARC in number. So our function or our essential role in the Saudi Medical Referral Center is oversighting and organizing referrals. This is through a unified platform that all hospitals across the kingdom speak to each other. A case that needs to be referred from one hospital to other hospital, it will be uploaded there in the system. All the hospitals can see this, and whoever had the capacity and the capability to accept the patient, this will happen. Previously, pre-COVID era, this platform was there. It was not activated on a national level. It was humbly adopted by other sectors or other healthcare sectors rather than Ministry of Health. Nowadays, adopted by most or even all healthcare providers facility or healthcare facilities. In 2021, we reached about 389,000 referral or transactions that have been done through this platform across the kingdom between all healthcare sectors, the Ministry of Health sectors and other governmental sectors, with a daily average of 70 life-saving referral, 320 urgent referral, and 680 routine. So each type of referral had its own definition, time frame for acceptance and escalation. What happened during COVID in this manner, all healthcare sectors, all providers collaborate with each other. We move patients from hospital A to hospital B when there was a pressure or high occupancy in certain area or certain hospital. This shows a great impact on the smoothness and the easiness of fighting the pandemic throughout the nation. Can you go to the next slide, please? Speaking about medical evacuation, for example, during 2021, we reached around 1,800 plus medical evacuation trip during the year. It was divided between life-saving, urgent cases, routine, and even ECMO cases and international. Our role in the center to receive any request of medical evacuation that initiated from any hospital, then review it based on our standards, prioritize the request, and then send it to the vendor or the private or the airplane vendors. So either Ministry of Defense or other partners. What was special during COVID and the air medical evacuation experience? We all remember that those days that we never want to, no one is excited to have it again. When the curfew was there, when no one can travel, when no one can move, airports was shut down. So what happened during that time? We gather all the information about all the patients who had critical follow-ups, critical diseases, chemo patients, cancer patients, patients who need, who cannot skip their appointments. And that time, the flights was ongoing. All medical evacuation trips was ongoing during the curfew and the early era of the pandemic. We transferred patients from area to area just for a chemo session or for continual follow-up. This was the high priority for everyone in the country, for everyone in the ministry, to make sure that no one will be affected during those days. Collaboration between all the healthcare sectors, all the vendors was there. It was happening smoothly. Thanks God we reached this huge number. Nowadays we're speaking about February. We end with 210 medical evacuation trip across the kingdom internationally within only 28 days period. Can we go to the next slide? Not trip, please. So speaking about bed management, one of the essential role of our center was monitoring the capacity and the occupancy of beds and bed occupancy in the hospitals. ICU beds, ward beds, that was happening through a platform that each hospital has an access to it. They update or integrate their HI system to this platform. So the higher level management, the control, and the stakeholder and decision maker was always updated about the bed situation, bed capacity, and occupancy rate. This was very helpful during the pandemic. So it was utilized to manage pressure and get back the equilibrium between the regions and the hospitals even. So when region X was under pressure, all the resources and facility will move there either to support with manpower or to decompress by sending patients who can be sent through all the facilities, either ground transfer or air trip to other regions where the situation was much better or easier. This showed a huge impact on the performance and the fight against COVID. Currently, this platform are connected to a huge number of HIS system, so no need to update, no need to get and to log in and update your bed status. It's directly integrated with most of Ministry of Health hospitals through HISs. Can we go to the next slide, please? ICU portal. So this was a very challenging questions and challenging task. Everyone was interested to know how many ICU patients, what was the demographics, risk factors, why we are having, why patients get admitted to ICU because of COVID. From there, we started here in the center with the support of the leaders and stakeholders, a platform that every hospital has a user and access to update and to upload their COVID patients. So it will make the decisions much easier. It will give the stakeholders and decision maker the insight about whatever happening through secondary to COVID, number of patients of COVID patient in critical care, number of admissions, number even of COVID patient in wards. And this platform is automated platform. Each hospital updates their patients on this form based on the policies and procedures that agreed across the whole or the entire healthcare system within the country. Can you go to the next slide, please? So speaking about telemedicine, virtual care, and this is somehow very similar to what Dr. Abdul Aziz Alhamud was speaking, my colleague Abdul Aziz. One of the main role of our center was Lifeline Center, or in Arabic خط إنقاذ الحياة. So this center started a few years ago in very small scope, very limited scope, covering few regions. Then more than 2 years ago, it's become a national center. So our scope in Lifeline Center, we receive 24/7 calls from any healthcare provider at any sector. It doesn't matter, this is Ministry of Health, this is private sector, other governmental sector. So we serve everyone. So this center is staffed by a frontliner who are paramedics and nurses well trained to receive and dispatch calls. So once they receive the call, based on the category and the type of the call, they refer it to one of 12 consultants on call in the hospital and in the back end of the center. All of them are in critical specialties. So our job here to give second opinion, to give help in the initial plan and management of the patient, to give online medical direction, and also to facilitate and ease the need of life-saving transfer. So, for example, if in a hospital, Dr. A called from hospital, he had a patient that he needs a service or she needs a service which is not available. And this was a life-saving case in that hospital. So immediately after making sure that the patient received the optimal treatment and stabilization, we give the authorization and the arrangement to move this patient promptly from this hospital to the nearest hospital with the available facility. Speaking about numbers, can you go to the next slide, please? So 2021, we received almost 70,000 calls to the center. We move or we transfer as life-saving about 20,000 cases. The rest of the calls was as consultations and second opinion and follow-up calls. Major specialties that we cover in this center: adult emergency, pediatric emergency, adult ICU, pediatric ICU, also NICU, EpiGynae, ECMO services, infectious disease, and also clinical toxicology, hematology, and oncology for especially acute leukemias, and lastly, neurology for acute stroke and thrombectomy. Thank you. So can you go to the next slide, please? Poison Center, which is part of the Lifeline. Here we have a dedicated staff who are also providing service 24/7, clinical toxicologists, MDs who are frontlined by also nurses and pharmacists. As when we receive the call, we follow a protocol. So we received almost 2021 around 35,000 calls. It was from community and from healthcare providers. The main role of the Poison Center also to provide consultation to healthcare worker in case of any toxicological case, community and public consultation if need, when we get approached, and also notify authorities when any triggers there, especially when a certain poison was red flags or a trigger or a trend for a certain use of any substance. Can you go to the next slide? Speaking about COVID, we all heard about COVID and ECMO and how was the era of ECMO, especially in the early time of COVID. For that, early in 2020, we started the idea in our center also, which was connected to the Lifeline Center, our mobile ECMO team. So our mobile ECMO team was consistent of ICU consultants, cardiac surgeon, ICU nurses, respiratory therapists, and perfusionists. So they were in call 24/7. We started with one central team, then we increased it to 3 to 4 teams, covering regions of the kingdom. So whenever we receive a consultation through the lifeline for a patient with ECMO, this team will be notified, a process that to be followed. Then the decision will be taken either to go or not. Can we go to the next slide, please? So speaking about ECMO, since beginning we received almost 900 consultation, 170 almost or 169 of them was retrieved by ECMO team. 80% was through ground transfer, and around 20%, which is around 20 plus cases was, or 30 plus cases, sorry, was transferred through medical evacuation. So our process there, once we receive a call from a hospital, from a physician that thinking his patient need an ECMO, there was an ECMO referral form, criteria for ECMO that to be filled by the physician and then reviewed immediately by our on-call team. So if the criteria was matched, immediately the nearest team will be activated and they will go to retrieve the patient. So a full team will travel either by ground transport or air transport to reach out the patient, cannulate the patient and get him or her back to the ECMO center. When this started, we was having only 1 or 2 ECMO center, and currently now we are speaking, we reach out, thanks God, around 11 to 12 ECMO center across the kingdom. Can we go to the next slide, please? So this is basically what was going through COVID. This was a collaboration between every healthcare provider, between every healthcare sector. Without the support, without the initiation from every one of us, this will never be happen. Again, thank you for having this, and we are all proud to be part of all what happened during this. Thank you so much for this, and the mic is yours.
Thank you very much, Dr. Mohammed, for this presentation, and thanks to the team in Saudi Medical Appointment and Referral Center. Now we would like to go back to Dr. Yasser Al-Asqa, the Director General of the Saudi Patient Safety Center.
Thank you so much, Lamia. Welcome back, everyone. After this very short presentation, I'll be very happy to respond to any questions you guys have. I'll answer them to the best of my abilities, or if any of the speakers are still with us, we can divert the questions to them. Next slide, please. So in these few slides, I'm going to talk a little bit about the effort that was done in collaboration with other centers, but was spearheaded by us in the Saudi Patient Safety Center. This is briefly the number of cases, the total number of cases, total number of deaths, critical and tests done since the beginning of the pandemic. Next. To date, in Saudi Arabia, we have delivered more than 60 million doses. Around 1/3 of them are second dose, and around 1/4 is third dose. Next, please. Now, talking about Saudi Patient Safety Center, Some projects were done from the beginning of the pandemic to try to facilitate and help healthcare providers and community deal with the pandemic and to recover. Starting from the left to the right, the first thing that was from the right to the left, sorry, the first thing that was published with the Saudi from the Saudi Patient Safety Center was the patient safety recommendation during COVID-19, what to do when you're quarantined and isolated. This document was published in collaboration with the Saudi MOH and Wuqaya and others. After that, in collaboration with some educational centers, we've created virtual scenarios for digital training using simulation for healthcare professionals to identify and deal with COVID-19 suspected and confirmed cases. This was done through Buddy Interact company. And then with collaboration with the NFPA Middle East, the Saudi Patient Safety Center co-authored the Civil Defense Personnel Guideline to deal with COVID-19. And as everyone knows, healthcare, especially elective and semi-elective cases were postponed, and a lot of patients were affected by that. So the Saudi Patient Safety Center helped in co-authoring the Healthcare Business Continuity Plan and Planning Guide that was adopted by the Saudi MOH and other sectors in Saudi Arabia. During the pandemic, there were interim guidelines about how to prioritize cases, especially with in high-risk levels. So when do we say that this patient cannot be postponed, especially when it comes to surgery? And there was a guide also during COVID-19 for community pharmacies and how can they deal with the surge of cases. Next, thank you. Some other activities was the National Patient Safety Award 2020, which was one of the main themes was about efforts and response to COVID-19, where the Saudi Patient Safety Center recognized researches, quality activities, and centers that were aimed towards improving healthcare during COVID-19. The Saudi Patient Safety Center also, as a WHOCC, a collaborating center, shared and disseminated a lot of resources supplied by the WHO EMRO regarding mental health and psychological support for healthcare providers, especially because the COVID-19 caused a surge of burnout in healthcare providers. Something that was done during COVID-19 era, but it's not significantly related, was the safe staffing ratio, especially when it comes to nurse and midwifery services to patient ratio. This problem was definitely highlighted during the COVID because of the shortage of staff, which pushed us to create general guidelines regarding safe staffing ratio. Some supplementary recommendation about non-punitive response during COVID. We know that everyone didn't have enough rest. A lot of people were working longer hours without vacation. So errors were prone to happen. And the Saudi Patient Safety Center at that time saw it necessary to release a supplementary recommendation about non-punitive response to error during that time. SPSC also initiated a series of community talks, lectures, with the goal of empowering patients and the community to live a healthier lifestyle during COVID. And lastly, COVID-19 safety guideline for healthcare professionals, again, mainly aimed towards psychological safety and psychological support. Next, please. Other community engagement activities during COVID was a campaign about vaccination, knowing that the Saudi Patient Safety Center is closer to the community, especially when there were doubts about the campaigns. So we released a few factoids about myths and reality and how safe the vaccines are. And we translated the evidence to terms that are understandable by the public. Another campaign was about hand hygiene. That was a very big campaign for both community and healthcare providers. Patient and healthcare providers forums, there were a few forums that were done during COVID-19. Again, public webinars and Hakaya Salama that were true patient stories that were shared with the public. Next, please. These are some of the activities that were done internationally with the WHO, other WHO collaborating centers and WHO EMRO, around 1,100 attendees from 48 different countries. This was during the pandemic. Next, please. And I think that at the end, I would like to thank all the scientific societies that helped us create the scientific material and translate it to terms that are understandable by the public during the pandemic. So this is a list of some of the scientific societies that helped us. Next, please. I would like to end here and thank all the speakers for their valuable input and time. This was a very this was a very informative and short seminar where we showed a lot of effort that we are proud of on behalf of the Saudi Arabian government. And this shows that it was not a single entity or one body effort. People who presented to you today come from 4 or 5 different sectors, and we wanted to involve more and more and more people from other sectors to talk about their collaborative experiences. There were no borders in transferring patients during COVID. One of the things that I'm personally very proud of, that there was no eligibility criteria. Everyone who was a resident of Saudi Arabia, whether legal or illegal, had free healthcare for COVID cases, even for vaccination. This is something that was something that really makes me very proud to be a person who works in Saudi Arabia and a citizen of Saudi Arabia. And with this, I will close my talk. Lamia, do you want us to go through some of the questions that were not answered?
Thank you very much, Dr. Yasser. I think since we have 18 minutes left, we can go through some of the questions, and we have Dr. Aziz Alhamud with us and Dr. Mohammed Tuwajri and also Dr. Mohammed Arafat. Some of the questions can be transferred to them. So if you would like to give us the honor of reading the questions, Dr. Yasser.
Shukran, Lamia. Dr. Arafat, if you can hear me, can you talk about or elaborate a little bit more about cross entity or cross sector transfer, especially in life-threatening COVID cases? Because in normal operations, in normal days, this was not easy to do. And then the other question to Dr. Arafat and to Dr. Mohammed Tuwajri from Red Crescent, how about hospitals that were overwhelmed? How did we divert patients, especially from pre-hospital care?
Assalamu alaikum. Speaking about patient, moving patients or transferring patients, this was supported by the higher authority in the country. So everyone was collaborating. This was happened through national committees, also national groups. So whenever a city or a region was or with high occupancy rates, so all the activities, all the resources will be moved there from manpower, from attention to decrease to support this. So there was no borders, there was no eligibility criteria, as you mentioned. We moved a patient from hospital to hospital according to the need, not according to any other restrictions or criteria. And this shows a huge impact on the smoothness and easiness. Plus also the authorization of life-saving. So whenever the center decided or the on-call team decided that this is a life-saving, so there was only a notification for the receiving hospital that you are receiving these patients. No need for a pre-approval. This is arranged through monitoring or through having the scope of service background of each hospital and monitoring the rate also for the hospitals. And maybe a part or a small part from the pre-hospital. One of the huge collaborations that happened recently during COVID between our center and the Red Crescent Authority, that wheeling the hospital diverging, or the ambulance diverging from hospitals to the bed occupancy rate. So we have the data, we have the information about the bed occupancy, and they don't have this insight. So whenever there is a high occupancy in the hospital, and it was requested, a diversion requested. So we collaborate, we integrate with the Red Crescent Authority to validate this and approve it. And it's not only about approving. So if we approve it, we go and approach this hospital and try to help out or figure out what can we do, either moving patients or diverting is enough for a few hours. Or transferring 1 or 2 or 3 patients, and in order to reach the acceptable occupancy rate again. I hope this is clear for you, Dr. Yasser.
Outstanding. So the diversion request was more of centralized rather than the hospital asking the Red Crescent directly. It was like a 3-faceted process.
Yes.
The other question for you, Dr. Arafat. Maybe it's not related to COVID, but were lifeline cases analyzed from a quality perspective? Like, do we have a quality assurance program within lifeline cases? Are they audited?
So we have a criteria definitions that we work on. We work and we follow. Always there is opportunities. So first of all, the system is VR system or interactive voice system. So all the discussions are recorded, retrievable, so nothing will be missed. We have in the system also in the platform a feedback icons from the receiving hospital. For example, if we received a call for a patient that during the call we agreed that this is a life-saving patient, and we give the order to do 1, 2, or 3 in order to stabilize. Then if the patient reach out the hospital in critical situation or unstable or unsafe situation, the receiving hospital have the capabilities and the ability to feedback us with this, and in order to us to action this and ticket this, even if it's an issue in the medical management will approach the physician if it's an issue in delay in transfer. So whatever was the issue, we have a pathway for it. We have an agreement also and SLAs with the medical evacuation providers. So when it's about life saving, we have timeline to approve the request and to move the airplane within a time frame. We have KPI for it. It is monitored and updated every night.
Thank you, Dr. Arafat. Dr. Twajri, if you can hear me. During COVID-19, so basically the same question, where hospitals were overwhelmed during the surge of cases, hospitals were overwhelmed. How difficult was it to divert cases from hospitals to hospitals or from the field to the hospital, especially when there was diversion?
Thank you for the question. Actually, as you mentioned, there was a very big difficulty about these issues with receiving hospitals. But we have the collaboration with the hospital and CCC in each region So we can divert the cases according to the occupancy rate of the beds in either in emergency or ICU beds. We have categorizing the patient either critical or what we call it stable patient. So if there is a critical patient, we should transfer it to the nearest suitable hospital. The capability to treat this patient. And with the collaboration with the CCC, we just distribute the cases around the same region or the same city. Also, we have the hospital bypass policy that will be reported by our online medical control. We have the right to give the order to hospital bypass if there is surge capacity in hospital. And we face this, I think, in some cities in the kingdom, like Riyadh and Jeddah, Mecca, also Medina. So there was some issues, but I think we solved it very well with the collaboration with other entities.
الله يعطيك العافية دكتور محمد. Dr. Abdul Aziz Alhamud, I have a question that also someone asked it, and أول شيء good to see you. It's been like 10 years ما شفتك. So talking about telemedicine, it's not only that you have to convince the public, you also need to convince healthcare providers that you are providing the same quality of care. This is a very big challenge from my point of view. The great thing that happened in COVID, يعني كانت محنة ومنحة at the same time, that it gave us, it accelerated so many things worldwide, especially in medicine, and brought telemedicine and virtual care to the front, where it was a luxury and now it's more of a necessity. So my question to you, do you perceive that it's going to be difficult convincing patients and physicians that we can provide good quality or enough and safe care?
Yeah, definitely. Thanks, Dr. Yasser. Excuse me. Yeah, so the good thing about virtual care after COVID is that there's a lot of evidence published for physicians and for patients to actually use it. And people were kind of pushed to try it. So almost even surgeon, ophthalmologist, trauma surgeon, and name it, they were kind of pushed to learn how to do it. Maybe they learned it the hard way, but one of the things that I share with physicians today is a very well crafted paper by Stanford that tells you how to do physical exam virtually. So even if they talk about virtual, how am I how am I going to evaluate my patient? They say there's an evidence behind it. You go and learn how to do it. The challenge that we see is being confident that the service will be available, that the patient will understand what I'm saying, and all the transcription error, the communication, the team management, when I say something to the patient remotely, or when I work with a physician remotely and we agree on a plan virtually, did they get it completely? Are they learning, like, are they getting with what I'm doing, my body language, my communication skills, voice tone, and on all these aspects? We work on something called screen side manners. We want our physicians to practice taking into consideration that there is a video, then nobody gonna see your the rest of your body language, for example. The tone is, yeah, this is basically what we do. And again, it is a challenge, and we're tracking this closely.
How about patients? Do you perceive that it's going to be difficult to convince patients that we're going to deliver as good, as safe care as we do physically?
Yeah, this is really takes us to a funny story that always the first appointment virtually is hard. The second appointment, we don't need to worry about. Once they go through it, once they see the value, once they feel like this is a perfect experience. We have a dedicated team who call right before the appointment, explain to them how to go through it. Because when we designed it, we used experts in the field, but we want to design it to the lay people.
Perfect. شكرا دكتور عبد العزيز. one last question I had here in my notes was talking about medication delivery and access to medication during COVID. One of the things that was really great and that was done during COVID, that a lot of governmental and non-governmental hospitals or healthcare sectors contracted with courier and delivery services, and medications and re-prescriptions were delivered to patients at their homes, which is something that is definitely made us avoid a lot of harm by missing medication. I think we are ready to close.
Thank you very much, Dr. Yasser. I would like to close by thanking Dr. Dalia Mu'min Khan, Dr. Mohammed Tuwajri, Mr. Ali Shahrani, Dr. Abdul Aziz Alhamud, Dr. Mohammed Arafat, Dr. Imad Lafi Al-Muhammadi, Dr. Khalid Abdul Karim, Mr. Walid Amrud, and you, Dr. Yasser Al-Asqa, for this amazing seminar. Hope our audience have benefited from this information, and hope to see everybody from our audience to our speaker in our next events. Thank you very much, and have a good day.
Thank you so much, everyone. Be safe. Assalamu alaikum.